Hello, everyone, and welcome to the Cottage Structural Heart Clinic's Meet the Doctor, featuring Dr. Michael Shenoda, an interventional cardiologist and structural heart disease specialist with Cottage Health's Structural Heart Clinic. I'm Christina Cortez, the Public Relations Manager for Cottage Health and your moderator for this session. Thank you all for being here today. Before we get started, I'd like to review a couple of housekeeping items to help make sure you get the most out of this virtual event. At the end of this presentation, we'll have a brief question and answer session. So if you have any questions, feel free to submit them using the Q&A button at the bottom of your screen. This presentation is being recorded, and within the next week, you will receive an email with a link to view the presentation and PowerPoint slides. So now it's my pleasure to introduce Dr. Michael Shenoda. Born and raised in Southern California, Dr. Shenoda attended medical school at Michigan State University. He attended the UCLA Olive View program for internship and residency in internal medicine. His cardiology fellowship training was performed at the Cedars-Sinai West Los Angeles Veteran Affairs Combined Program, where he was chief fellow. He then underwent interventional cardiology fellowship training at UCLA, and he moved to Santa Barbara, where he is now a structural heart disease interventional cardiologist at the Cottage Heart and Vascular Center. He performs complex percutaneous coronary interventions, transcatheter aortic valve replacement, left atrial appendage occlusion, transcatheter edge-to-edge mitral valve repair with MitraClip, transcatheter edge-to-edge tricuspid valve repair with TriClip, atrial septal defect, patent foramen ovale closure, alcohol septal ablation, peripheral interventions, and paravalvular leak repairs. He also participates in numerous clinical trials, serving as a local principal investigator or co-investigator for multi-center trials and investigator-initiated ones. He has served in various leadership roles, including department chair, and he is currently the vice chief of staff at Santa Barbara Cottage Hospital, and he will be transitioning to chief of staff in 2026. So with that, please join me in welcoming him.
Thank you, everyone, for joining me this afternoon. I will start sharing my screen here, so hopefully you guys can see that okay. This afternoon, we will be discussing reducing stroke risk across the age spectrum, and in particular, we will be reviewing interventional therapies for stroke prevention. I hope you guys enjoy the talk, and I will be more than happy to answer questions once we have gotten through the slides and gone through the talk. So without any further ado here, so what exactly is a stroke? So a stroke occurs when blood flow to the brain is blocked, and this can happen in one of two major mechanisms. The first mechanism is when a blood clot travels to the brain, and this can be a blood clot that's formed elsewhere in the body, such as in the heart, or it can be a blood clot that breaks off of a plaque in the carotid artery. This blood clot travels to the brain and unfortunately blocks that blood flow to that area of the brain, which causes brain tissue death. Now, another mechanism for a stroke is when you have an aneurysm or a small outpouching of the vessels in the brain, and that can burst, unfortunately, and can lead to bleeding into that brain. And the brain is in a small confined space, and so when blood pools into that small confined space, that pressure can build up, and that can also lead to brain tissue death as well. So what are some of the risk factors for a stroke? Well, turns out that about 80% of stroke risk factors are actually ones that are controllable. And these include such as high blood pressure, type 2 diabetes, high cholesterol, physical inactivity, and tobacco use. Now, another risk factor for stroke is atrial fibrillation. And atrial fibrillation is an erratic and irregular rhythm that originates in the top chambers of the heart, what's known as the atria. And the way that atrial fibrillation leads to a stroke is when that top chamber of the heart, when it fibrillates, a blood clot can form in that top chamber of the heart, especially in a small outpouching called the left atrial appendage, and that blood clot can travel to the brain. And so with atrial fibrillation, you have an erratic rhythm. Now, this is a schema of the electrical conduction system of the heart. And I know it looks complex, but I'll walk you through it here with my cursor. So the top two chambers of the heart are known as the right atrium and the left atrium. And the left atrial appendage is a small outpouching. This complex electrical system, which starts with electrical circuits in what's known as the sinoatrial node, it travels down through the atrial septum as well as throughout the right atrium, travels through the left atrium. And once it goes down the atrial septum, it comes to a gatekeeper known as the atrioventricular node, and that allows the electrical circuit to move on to the right and left ventricles of the heart. So the way that I want you to visualize this is a single file line going through a single door. Now, what happens with atrial fibrillation, this is an erratic and chaotic rhythm. And what you see first of all, that sinoatrial node, it's no longer firing. You have all these electrical circuits within the right and left atrium that are firing almost like to the beat of their own drummer. And they're erratic and they're irregular and they're going all over the place in these multiple reentrant circuits. And then you have these firing down into the AV node at a very rapid rate. And the AV node, which is the gatekeeper, is trying to keep up with all these electrical circuits coming from different areas of the top chambers of the heart and trying to allow it to pass. So rather than that single file line going through that door, now you have a stampede trying to make its way through the door, and the AV node is trying to keep that stampede from taking it over and going into the ventricle. And when it's not successful at doing that, that's when you get those erratic and rapid heartbeats that patients can have with atrial fibrillation. Now, the way that atrial fibrillation forms a blood clot is that top chamber of the heart known as the left atrial appendage, which is a small embryological vesicle. Well, stagnation of flow forms. So imagine taking a plate of Jell-O and just shaking it. That's what's happening with the blood in that top chamber of the heart. And that can lead to a clot, as shown here by a transesophageal echocardiogram. A clot has formed there. Now, about 90% of blood clots that occur in atrial fibrillation occur in the left atrial appendage. 10% will occur elsewhere in the atria, but 90% will form in this small outpouching of the heart known as the left atrial appendage. Now you may ask, well, how does a blood clot from the heart get to the brain? So looking here at this picture, once atrial fibrillation forms in that blood clot, sometimes it can get ejected out from the heart. And that can happen when patients go in and out of AFib, or sometimes even when they're in permanent AFib, that clot tends to move out. And when it does move out, it moves out across the aortic valve into the aorta, and it can actually go as a direct path up one of the internal carotid arteries to the brain. However, the path of least resistance, even though it's up the carotid arteries into the stroke, and that's the most common thing that we see, sometimes we can see it going down the aorta, and it can also travel to other organs and lead to havoc in other vasculature beds or limbs as well. So atrial fibrillation is the most common rhythm disturbance that we see in patients over the age of 65. And as demonstrated by this graph, the incidence of AFib is pretty low in patients in their 50s and 60s. But once you start to get to 65, you can see that the incidence of atrial fibrillation increases with age. And in patients in the 80-year-old range and above, the atrial fibrillation rates are as high as about 10%. Now, this occurs in both men and women. Initially, men have a high rate of atrial fibrillation, especially in their 60s and 70s. But as you can see, women do catch up in their 80s. As you can see, the slope of the line is much steeper than the slope of the line that you see on the men's graph. So again, by the age of 80, there's a high likelihood that both men and women will have developed atrial fibrillation. Now, we are seeing more and more atrial fibrillation in our society, and that is probably coming about from several factors. One, people are living longer. And two, we're getting better at diagnosing atrial fibrillation, especially with a lot of our newer technologies and our wearable technologies. We're able to better document episodes of atrial fibrillation than we were even a decade ago. So looking back in 2018, there are approximately 6 million people living in the US with atrial fibrillation. And now it's estimated that we're going to double that number to 12 million by the time we hit 2030. And this is important because we know that atrial fibrillation increases the risk of stroke by about 5 times or 5-fold. And in fact, 1 in 6 strokes occur in patients with atrial fibrillation. Now, patients ask, how bad is my atrial fibrillation? And we do have a staging system for atrial fibrillation, and the staging system is based on how much time a patient spends in atrial fibrillation. So something known as paroxysmal atrial fibrillation is atrial fibrillation that is intermittent and terminates usually within about a week of onset. Someone that is in persistent atrial fibrillation has had ongoing atrial fibrillation for longer than a week. Someone with long-standing persistent atrial fibrillation, they've had it continuous for over 12 months. And someone who's in the permanent atrial fibrillation category, those are patients that they have been in it for so long that you refocus the treatment from a rhythm control strategy to a rate control strategy. So what are the pillars for AFib management? So in every patient that we see with atrial fibrillation, the first and most important thing is to assess and treat their stroke risk. The second thing that we focus on is symptom management. Some patients with atrial fibrillation have symptoms while others don't. Regardless, we want to be able to try to control the rate so that way they're not always at an elevated heart rate, and that's called a rate control strategy. A rhythm control strategy focuses on trying to get the patients out of AFib into a normal sinus rhythm. Now, we won't focus on rhythm versus rate control because that is a very complex topic that can take up the whole hour if we spent talking on it, and it's really for another different talk. But what we will focus on is assessing someone's stroke risk and how best to treat that stroke risk. Now, obviously, as I mentioned, 80% of the risk factors are modifiable, and it's always important when you're seeing your doctor to address those modifiable risk factors, such as obesity, tobacco use, hypertension, alcohol use, diabetes, and sleep apnea. So how do we assess someone's risk for stroke that is having atrial fibrillation? We use a risk factor-based approach and a scoring system. And the scoring system is known as the CHADS-2 VASC risk score. And this we assign a point or two depending on the patient's risk factor. And your maximum score is 9. And based on that assessment, we're able to know what your risk of stroke is and what the chances are that you will be better off with a blood thinner than without it. So the risk that we look at is patients with congestive heart failure will receive a point for this. Patients with high blood pressure will get a point. If you're older than 75, you get 2 points. If you have diabetes, you get a point. If you've had a previous stroke or transient ischemic attack, you'd get 2 points. If you have a history of vascular disease, you get a point. If you're between the ages of 65 to 74, you get 1 point. And if you're a female, you get a point because females tend to present a little later, as I showed, and have more comorbidities, which leads to a higher risk of stroke. So as you can see here in the second window, as your CHADS-2 VASC risk score increases, so does your risk of stroke. Generally, if you have a CHADS-2 VASC risk score of 2, which puts you at about a 3.7% risk of stroke each year, that's the time that we do recommend placing a patient on a blood thinner. If you have a CHADS-VASC score of 0, we tend to not recommend blood thinners unless they're undergoing a procedure like an AFib ablation or a cardioversion. And if you have a CHADS-VASC score of 1, that is up for discussion between you and your physician in terms of the risks and benefits of placing a patient on a blood thinner, as the stroke event rate there is about 2%, and with blood thinners, we're able to cut it in half to 1%, but not 0. So the mainstay of therapy for reducing stroke is blood thinners or oral anticoagulation therapy. And these are used to reduce the risk of clot formation and strokes. So just like that slide that I showed you that showed that clot there, if you're on a blood thinner, that blood thinner would help keep that blood from clotting in that top chamber of the heart. So one of the medications that we use for oral anticoagulation therapy is warfarin. This has been around a very long time, and we have extensive data with it. It's fairly inexpensive, and it is effective. but it's not a great medication as it has downfalls like every medication does. The downfalls of warfarin are there's a very narrow therapeutic window. That is, we have to be able to treat you within a certain window of thinness of the blood to be able to reduce your risk of stroke without increasing your risk of bleeding. And that requires blood monitoring. And everyone is on a different dose, usually a different dosing regimen than most people, depending on how your body reacts to warfarin. So it can be difficult and time intensive to manage. A lot of people are uncomfortable with warfarin because warfarin has been used in the past as rat poison. So the reason why we like warfarin is because, without a doubt, when you're within that therapeutic window, it is highly effective. And looking here at placebo, which is in blue, and warfarin, which is in red, your reduced stroke risk with warfarin is about 80% when you are consistently within that therapeutic window. So the newer kid on the block are known as the direct oral anticoagulants, DOACs for short. And these work through a different mechanism compared to warfarin. They do not require monitoring. It's a fixed dose. Some of the doses tend to get reduced depending on age and weight and body weight. And generally, they have a lower risk of bleeding. So they have a lower bleeding profile than warfarin. And these have been out for about a decade now. And despite being out for a decade, they're still fairly expensive. In addition, they in the past have been more challenging to reverse the blood thinning effects, whereas with warfarin, you can reverse it with something like vitamin K. These require an antidote, which initially was difficult to obtain, but now over the past 5 or 6 years has not been an issue to obtain. And most hospital emergency rooms and ORs are fairly well equipped for patients that come in with bleeding on one of these DOACs. Some of the examples, as you've probably heard through media and advertisements, include Eliquis, Xarelto, Pradaxa, and Savasa. The first three are the ones that are most used in the US, and Savasa or Doxaban is used overseas mostly. So I know this is a busy slide, but I do want to show you the trials that compared the effects of warfarin to the NOACs. And these are multiple clinical trials, and I'll walk you through it here for simplicity's sake. I will highlight what I want you to focus on. So looking on multiple clinical trials, when you compare the effects of DOACs to warfarin on stroke reduction, the numbers here are very similar, if not a little bit better, on the DOAC side versus warfarin. And then when you look at hemorrhagic strokes, similarly, the DOAC numbers are mostly better than warfarin. So they are as effective or a little bit better than warfarin at reducing your risk of stroke, but they cause less bleeding into the brain. And that's what a hemorrhagic. The reason for that is the DOACs do not cross the blood-brain barrier, whereas warfarin does. And that's the hypothesized theory of why these agents are safer in terms of causing bleeding into the brain. Now, when you look at bleeding overall, including bleeds in other organs, they are also much less with the DOAC group than with warfarin. So the DOACs decrease your stroke risk as much or maybe better in certain clinical trials than warfarin, but they also decrease your risk of bleeding. And that's why physicians tend to prefer prescribing DOACs to patients over warfarin. Now, how do we assess bleeding? So bleeding is assessed through another risk score. And this risk score is known as the HAS-BLED system. And similar to the CHADS-VAS system, you get a point or two based on some clinical characteristics. And that includes high blood pressure, abnormal kidney or liver function. Each of those gets a point. If you've had a previous history of a stroke, you're at increased risk for bleeding, so you get a point. If you have a bleeding tendency or a predisposition to bleeding, you get a point. Labile INRs for patients with warfarin. INR is what we measure to measure the thinness of the blood. And if you are very difficult to control, you would get a point on the HAS-BLED scoring system. If you're over 65, you would get a point. And if you're taking other medications that can lead to more bleeding episodes, such as NSAIDs or aspirin, you would get a point, as well as excessive alcohol use. And the maximum point system is 9. And as you see, as your HAS-BLED score increases, so does your risk of bleeding per 100 patient years. Now, physicians are tasked with the ability of trying to figure out, okay, what is a patient's risk of bleeding and what is the risk of stroke? And so when you compare the CHA2DS2 score to the HAS blood score in a patient, you get a general idea, is this patient going to be able to tolerate blood thinners for a long time, or are they going to end up bleeding eventually? And a lot of clinical trials use these two scoring systems to be able to figure out which patients are appropriate for some of the interventional therapies that I'm going to discuss in the next couple slides here. So most of the trials that looked at left atrial appendage occlusion devices looked at patients with a CHA2DS2-VASc score of 3 and a HAS blood score of 2. And even though their annual stroke risk and bleeding risk does not match up 1-to-1, that's what the data safety boards looked at in these clinical trials. So when we offer therapies outside of oral anticoagulation therapy for stroke reduction, we always look at a CHA2DS2-VASc score of 3 or a HAS blood of 2. Now, unfortunately, as time goes on, your bleeding risk increases. That is, the longer you are on a blood thinner, the higher the chance of bleeding with time. And the bleeding risk compounds over time in an exponential standpoint. So even though your year by year HAS blood score may not change much, your risk of bleeding over several years increases over lifetime. In addition, taking blood thinners is a challenge. So even in patients that do get on blood thinners, in which only about half of them get on blood thinners for various reasons, about 50% will stop taking them. And even with oral anticoagulants, they'll still stop taking them in about 30% of the time at 2 years. And with warfarin, 50% of those patients will stop taking them at 2 years. And this can be for various reasons. Sometimes it's a medication intolerance. Sometimes it's a bleed. Sometimes it's an expense. The medication is too expensive to take. So for these reasons, we do need other therapies other than blood thinners. And that's where alternatives to anticoagulation therapy first arose. So there's two current options. One is a surgical option, and the other one is percutaneous or transcatheter through a small incision in the leg. The surgical options have mostly been reserved for patients who are undergoing open heart surgery for another indication, whether they need bypass surgery or they need a new heart valve. Those are the patients that we mostly will refer for a left atrial appendage ligation, which can occur either through a suturing mechanism, a stapling mechanism, or simply tying off the left atrial appendage and cutting it off completely. But in patients that don't have a need for open heart surgery, it's pretty rare that we will send a patient to have their appendage removed surgically unless they have failed other percutaneous options. And so what are the percutaneous options? Well, we have two devices that are currently FDA approved for left atrial appendage closure. The one to your left here is called the Amulet device, and the one to the right is called the Watchman device. I will focus now just on the Watchman device, as it is in its fourth iteration. It has a lot of data. It's the device that's most commonly used in the US and has great outcomes. So the Watchman device is a small transcatheter plug, if you will, that will go into that left atrial appendage to stop blood clots from forming there. And I'll show some examples of that. So it's a one-time procedure. It's a permanent implant that stays there forever. It's minimally invasive through a small catheter that's inserted through the leg. It goes up into the IVC, into the right atrium. We create a small hole in the top chambers of the heart. We pop over to the left side and we deploy this device. In over a 6 to 9 month period of time, the tissue will heal around the device and the implant is there forever. And that left atrial appendage is now endothelialized with this device and can no longer have blood clot formation in that small top chamber of the heart. Most patients go home the same day. Some patients will stay in the hospital overnight and will go home the next day, as some of these procedures are done with general anesthesia, but they can also be done with conscious sedation and intracardiac echo. or transesophageal echo if it's under general anesthesia. Now, how does the Watchman compare to blood thinners? Well, the Watchman trials started out being compared with the gold standard, which at the time was a decade ago, it was warfarin. So when you look here at the solid line represents patients who are treated with warfarin, and these dots around that solid line are all the different clinical trials that was done with the Watchman device. And as you can see, all of these trials showed that the stroke reduction risk was either equivalent to warfarin or slightly better than warfarin. And indeed, the ischemic stroke risk with these patients is about 1%. And that's what you would expect with any blood thinner. It would be about 1%, again, because 90% of blood clots form in the left atrial appendage, 10% form elsewhere. And these were pretty high-risk patients with CHA2DS2-VASc risk scores of almost 5. Now, I do want to bring your attention to the dotted line, which shows what happens to atrial fibrillation patients who aren't on any blood thinners. Their stroke risk continues to increase per year and with increasing CHA2DS2-VASc risk scores. So this is the current device that we use here at Cottage Hospital, the Watchman Flex Pro. This one has a special coating on it, which helps prevent thrombus formation on the actual device as it's healing. And it also, this coating leads to less inflammation, which can lead to more device healing. It also has some radio-opaque markers, which helps us deploy the device, which I'll show you some examples of in a couple of slides here, and allows for better device sealing. And it has a wide range of sizes because, as you will see, no two appendi are alike. It's like a thumbprint. Everyone has a different size and shape appendage, and we have to find the right device to fit that appendage. So here's an example of a fluoroscopy or an X-ray with my Watchman device sheath with a pigtail, and we're injecting contrast, and this is someone's left atrial appendage, and that's the shape there. Over here, there's contrast swirling in the left atrium. This is a transesophageal echocardiogram, or this is a probe, like an endoscopy probe, with a ultrasound crystals on it that helps size and guide our Watchman deployment. So once we've gotten a size measurement and we know where the left atrial appendage is in terms of its size and shape, we pick a device based on several different sizes that come available in the Watchman. And here you can see that I've deployed a Watchman in that left atrial appendage. It's still attached by a core wire. So once again, we're assessing it by real-time X-ray and by real-time ultrasound with the transesophageal echocardiogram probe. Here I've injected dye to make sure that there's no dye falling behind the device, ensuring us that we have closed off the appendage with the Watchman. And indeed, once we're happy with our results, we're able to deploy the Watchman fully into the left atrial appendage. This is how it looks on transesophageal echocardiogram or ultrasound. This is my echocardiographer giving me a width size and a length size. We usually upsize these devices by about 20 to 30% bigger than the sizes that we get on ultrasound. So I want you to imagine putting a wine cork into a wine bottle. You want to get a tight squeeze, such as is shown here with this Watchman device. You can see it's kind of squeezed in there, so that way it doesn't move, shift, and that no leakages form. So this is another left atrial appendage that I'm showing you the difference in one patient to another in terms of the size and shape of an appendage. This patient has a previous history of a TAVR stent valve that was placed there, which makes it really difficult to try to image around that TAVR stent valve. And as you can see, my echocardiographer is trying to move his probe around that valve to be able to see the appendage better and be able to give me a good size measurement. Once we got the appropriate size, we're able to go around that valve, get a Watchman device deployed. We injected dye, and we got a great seal with no dye forming in the backside of the appendage. And then we released the device, and it looked fantastic after we did release it. Now, sometimes Watchman leaks can occur, and that's because the heart is still beating and the device can shift around there. And these leaks can occur anywhere from 3 months to a year. And so what do we do when we find these leaks? It just depends on the size. If it's a big enough size and there's a small outpouching that we're concerned about a blood clot formation, then we'll go back in and put what's called a vascular plug. So this is a Watchman device that has shifted, and I have a catheter through the area that there's a leak, and you can see contrast on the side of this Watchman device. And a vascular plug basically looks like a Tootsie Roll, right? You have this middle centerpiece, which closes up the hole, and you have two discs, one on the outside, one on the inside, which anchor it in place and fill that space completely, so that way there is no blood going back to the backside of the heart. So here you can see the contrast injection, and nothing is going back here any further. And this is how it looks on what we call three-dimensional transesophageal echocardiogram. The first arrow there is my Watchman device, and the second arrow is that vascular plug, which sits on top of it and prevents any blood flow from around the Watchman. And here you can see it on transthoracic echo, the vascular plug sitting on top of the Watchman, blocking any further blood flow from going to the backside of the heart and forming a clot. Now we're going to shift gears here from atrial fibrillation and stroke risk in patients on one end of the age spectrum, and that's mostly seen in patients, as I mentioned, in the ages over 65, to stroke risk with patients with patent foramen ovale on the younger spectrum of the age group, that is patients less than 60. This is something that's near to my heart. This is something that I worked on when I was at UCLA with my mentor, Dr. Jonathan Tobis, who's a world-renowned interventional cardiologist who specializes in PFO research. This is a paper that we published over 10 years ago in the Journal of the American College of Cardiology, looking at the treatments of patent foramen ovale and atrial septal defects. I will focus today's talk just on patent foramen ovales and their stroke risk and treatment options. So what exactly is a patent foramen ovale? Well, it's a communication between the top two chambers of the heart that allows unoxygenated or venous blood to travel from the right atrium to bypass the lungs and go into the left atrium where there's oxygenated blood. But why is that there in the first place? Well, it turns out that when we are in our mother's womb, we are dependent upon our mother to oxygenate our blood because our lungs haven't matured yet. And so because of the lack of ability of us to oxygenate our own blood, there needs to be a bypass mechanism. And what the foramen ovale is, it's a bypass that bypasses the lungs. So blood will come back into the right atrium, and rather than going into the right ventricle and out to the lungs for oxygenation in a fetus, it goes into the right atrium, bypasses the right ventricle and the lungs, and just goes straight into the left atrium, and that goes back out through the aorta, and then the blood is oxygenated by the mother's placenta. Now, what happens when we're born and we take our first breath? Our lungs expand, we're able to oxygenate our own blood, and then the pressures on the left side of the heart are higher than the right side. So that one-way flap closes. And when it closes, over 1 year of life, it starts to seal. Now, in 80% of patients, when it closes, it seals. In 20 to 25% of patients, it closes, but it never truly seals. And when it doesn't seal, that's known as a patent foramen ovale. So how does that lead to strokes in younger patients? Well, the theory is when you have a patent foramen ovale, even though the pressures on the left side of the heart are usually higher than the right side of the heart, sometimes the right-sided pressures increase and they become higher than the left. And when that happens, it can pop open that one-way door, if you will, and allow blood that hasn't gone to the lungs to bypass the lung and go across into the left atrium. So we have a very complex venous system and venous vasculature in which blood clots can form normally. And when those blood clots form, they usually go to the lungs and they get broken down, and no one knows anything better, right? But unfortunately, if you have a patent foramen ovale and there's a blood clot traveling to the right atrium at that time, and the pressures on the right side of the heart increase to being higher than the left side of the heart, such as can happen whenever you yawn, bear down, cough, or sneeze, that blood clot can again bypass the lungs, go into the left atrium, and then get ejected out, and it can go to the brain and cause a stroke. It can also go to other bodily organs and wreak havoc there as well, including the coronary arteries, which can be a cause for heart attacks in very young patients. We've seen this with PFOs, and it's an active area of research. So how do we know this? How do we know that this happens? Well, we've seen it. So here to the right side of your screen is a transesophageal echocardiogram, and I'll orient you here. This is the right atrium, this is the atrial septum, this is the left atrium. And what you're seeing here, flowing here, is an active clot moving around in the right atrium, going through the patent foraminal valley, getting caught in the tunnel, and flinging around here on the left side of the heart. So this is an active clot that's made its way through the PFO and hasn't made it up into the brain or other organ yet because it's caught in transit, if you will. So this is like the smoking gun, and we've seen this, unfortunately, and this is how we know about this mechanism of stroke in young people, which was described as early as the 1800s, when we obviously didn't have imaging like this. We've also seen this in some surgical specimens as well, and that's what you see here on the left, a blood clot traveling through the patent foraminal valley. Now, PFO-associated strokes is usually a diagnosis of exclusion, which means we have to rule out all other causes of stroke before we can say this stroke was caused by a patent foraminal valley. Small strokes are really hard for us to prove, as we can only see large strokes. And again, seeing a large clot go through a patent foraminal valley like this is pretty rare. Now, what are some of the risk factors for forming blood clots? As I mentioned, we have a complex venous system in which we're always forming blood clots, but these things tend to form more blood clots for us. And that's something like a deep venous thrombosis or a blood clot in the deep vasculature in the legs. That can be brought about by prolonged immobilization. So if you break a leg and you're in a cast or a brace and you're not moving that leg for a long period of time, blood clots can form in that leg. Long plane flights, very similar mechanism. That's why we always recommend to patients on long plane flights to get up and do some walking around to get that venous circulation moving so there's no stagnation of blood flow. Similarly with long car rides. Patients who take birth control pills or hormone replacement therapy can be at increased risk for forming blood clots on the venous side, and that can lead to strokes if they have a PFO. Patients with something called a hypercoagulable state. Now, these are blood factors that can be discrepant or low in certain patients and makes them have a propensity to form more blood clots, and sometimes these can be genetic deficiencies. And unfortunately, patients with cancer are at higher risk for forming blood clots because being in a state of cancer unfortunately leads to hypercoagulable states and sometimes deficiencies in some of those blood clotting enzymes. So if PFOs can lead to strokes, why don't we see strokes in 20 to 25% of patients if PFOs are truly prevalent in 20% of the patients? So it turns out not all PFOs cause a stroke. Only PFOs cause a stroke, and we're still trying to understand what are the factors that place patients at higher risk for strokes with PFOs versus those that don't. And here, this is a good example. This is something that came out of a stroke journal, which estimated in 2018 about 600,000 annual strokes. Now, 80% of those patients were over the age of 60, whereas 20% were between the ages of 80 to 60. Of those strokes in younger patients, 70% had a known cause, 30% had an unknown cause, what's known as a cryptogenic stroke. Out of those cryptogenic stroke patients, only half of them had a PFO. The other half didn't. So if a PFO caused a stroke, you would think that patients with PFOs and strokes would be much higher in our patient population than they really are, but they're actually not. So how do we know which strokes are caused by a PFO and which are not? Well, we go back to a risk score system. And I want you to think of this risk score system known as a rope score, risk of paradoxical embolism. A paradoxical embolism is when a blood clot from the venous side travels to the arterial side and causes a stroke, as almost the reverse of the CHAS2-VASc score. So this, we're assigning patients points if they don't have your typical risk, risk factors. So if you don't have high blood pressure, you get a point. If you don't have diabetes, you get a point. If you don't have a history of stroke or TIA, you get a point. If you don't smoke tobacco, you get a point. If you have brain imaging that shows that you've had an infarct that is more likely from an embolic phenomena or a clot that travels in that area of the brain, you get a point. And then based on your age, you get higher points when you're younger, lower points as you get older. Because again, once you cross that path of 65 to 70 years old, atrial fibrillation starts becoming a more predominant cause of stroke than a PFO. And that's why you have that discrepancy with 0 points if you're over the age of 70 and 5 points if you're between the ages of 18 to 29. Now, a rope score of 7 or greater is considered to be a high likelihood that the PFO led to a patient's stroke, assuming all the other workup has been unremarkable and we haven't found things like paroxysmal atrial fibrillation in these patients. So a better classification system that we now use that takes into consideration not only the rope score, but the patient's anatomy and relies a little less on age is something known as the Pascal classification system. So this is PFO-associated stroke causal likelihood. So as you can see, it does take into account the rope score of 7 or above, but it also looks at some of the PFO features such as a large shunt or something called an atrial septal aneurysm, where there's a bulging of the atrial septum, which leads to higher risk of clots traveling across that PFO. And depending on whether or not you have the high-risk features and your rope score, you can get a causal relationship, which is either probable cause, possible cause, or an unlikely cause. Now, PFOs are not just based on the size alone. That is, if you have a PFO, it doesn't mean it caused a stroke. And if you have a small PFO, it doesn't mean it didn't cause a stroke. There's a lot of anatomical variability within the top atria of the heart, which can lead to strokes. Things like an atrial septal aneurysm, which allows this pouching to occur, which blood clots can form and can get shunted across your PFO. Something called a eustachian valve, which preferentially directs some of the clots coming from the pelvic vasculature directly across the PFO. And other things known as a Chiari network, which is this complex webbing which some patients are born with in that top chamber of the heart, where even within the webbing, they can form blood clots and that can travel across the patent foramen ovale into the left atrium and lead to a stroke. So a lot of complex anatomical as well as risk factor considerations that we have to evaluate in these patients that come in with a stroke at a young age. So how do we make the diagnosis? Well, all patients that will come in with a stroke in our institution will get an echocardiogram with bubble study, and a bubble study is agitated saline that's injected through an IV to see if there's crossing of bubbles from the right to the left. They will get a simultaneous transcranial Doppler ultrasound, which is an ultrasound we put at the temples to see if there's any of those bubbles crossing up as far as the brain. Then we do what's called a transesophageal echocardiogram, which you've seen some pictures of, and I'll show you some more of a PFO. But the gold standard, ultimately, if those 3 non-invasive studies are questionable, is a direct heart catheterization where we put a wire through the PFO to see if it's open. So what are the treatment options for patients that have had a PFO and stroke? There's medical therapy, just like we have with atrial fibrillation, but with PFOs, some patients can be treated with antiplatelet agents, aspirin or Plavix, which is almost like a super aspirin. And in patients that are at higher risk, we can treat them with an anticoagulant, such as warfarin or Eliquis. We also have PFO closure techniques. In the past, in the 60s, 70s, and 80s, we'd have to send these patients to open heart surgery and do a surgical PFO closure. Thankfully, in the 80s and 90s, we've come out with percutaneous or transcatheter PFO techniques to close the PFO without open heart surgery. So what is some of the data that's compared medical therapy to PFO closure. There's a total of 7 studies, and this is one that Dr. Tobis put out doing a meta-analysis of 5 studies, which showed that when you take the totality of these studies and you look at medical therapy versus percutaneous PFO closure, the patients that got percutaneous PFO closure tended to do better than medical therapy. Now, a lot of these studies only looked at patients under the age of 60. And that's why, based on the 7 trials that we had looking at PFO closure versus medical therapy, the FDA approved PFO closure for patients with stroke under the age of 60. But the story doesn't end there, as I will show you. A lot of us feel like just because those patients were excluded from the clinical trials doesn't mean that they can't have a PFO-associated stroke. So how do we close the PFO? We put a wire through it through a vein in the leg. Once we cross the PFO, we put a catheter through there. We form a device on the left side of the heart, the left atrial disc. Then we form the right atrial disc. We bring them together. Once we're happy with them, we lock the device in place. And over time, tissue is going to heal up over that device and close off that shunt permanently. And that's a transcatheter PFO closure. And this is using a Gore device, which is one of the more common devices that we use here at Santa Barbara Cottage Hospital. So the current devices that are on the market are the 2 in the middle, an Emplatzer PFO occluder and a Gore cardioform septal occluder. In the past, we used the Starflex system, which is now off the market, as some of these feet would break off. And we're evaluating, and has already been approved in Europe, a suture-based system in which we leave no device behind, and we're able to close the PFO by a transcatheter suture that's left in place. So this is a diagnostic algorithm that was proposed by a stroke society. It's not the one that we use here, but it shows that we follow a logistic regimen in terms of looking at these patients that come in with PFOs. In our institution, we don't use the 60-year cutoff. So any patient that comes into Cottage Hospital, we're going to do an echocardiogram with bubble study and a simultaneous transcranial Doppler. And then we assess them based on their stroke risk with the ROPE score as well as the Pascal system. And if we think they're high risk for a PFO-associated stroke, we'll do the transesophageal echocardiogram. We'll do some prolonged 30-day monitoring to make sure there's no AFib. And then we discuss treatment, medical treatment versus PFO closure if this is a PFO-related stroke. So what's some of our knowledge gaps? As I mentioned, age greater than 60 years old, and that's because these patients were excluded from clinical trials. However, just this week, published in one of our journals was an article looking at patients who received PFO closure older than 60 compared to under 60. And what it showed is that the recurrence rate of TIAs and strokes in patients over 60 was similar to those younger than 60. Sorry, let me rephrase that. Those patients that got PFO closure older than 60 had similar event rates to those that were younger than 60. So I don't think that the story ends here in patients over 60. I think it's an active area of research. In addition, sex, race, and regional differences continue to baffle us. For example, in Sweden, they have the highest rate of PFO closures. And we don't really understand why there's such a high incidence of PFOs in young people there in Sweden. Atrial fibrillation can occur post-PFO closure as the device heals. There's some inflammation, and that usually resolves at about 3 months. But the question becomes, was the AFib there all along, or was it just brought on by the PFO closure? As I mentioned, the generalizability of these randomized controlled trials is always difficult to bring to the general population, as these trials are well managed in terms of medical therapy, and the reality of being able to implement that in society is very difficult. And then we're also looking at possible markers of casualty as well as risk, and the role of neurocardiology teams, which here at Cottage Hospital, we have a great neurocardiology team in which we work together side by side in these patients that come in with strokes that are suspected to be secondary to PFOs. So let's go through some slides. This is a transesophageal echocardiogram looking at a pain foraminal valley. So this is the right atrium, left atrium, and this is that tunnel opening up here. And as you can see, blood is traveling from the right side of the heart to the left side of the heart. Here we're measuring that tunnel, which helps me to be able to size appropriately which device I'm going to place there. This is an agitated saline bubble study. This is just bubbles that are agitated and saline in an IV, and you can see some of the bubbles going through the PFO to the left side of the heart. So this is a PFO closure. So here, this is my X-ray fluoroscopy. This is my wire going from the right side of the heart to the left side of the heart. This is an intracardiac echo, a catheter with an ultrasound probe. And this is showing me the PFO, which is right here. This is the right side of the heart, left side of the heart, wire going through the PFO. And this is that same wire that we're looking at here in the left upper pulmonary vein. So we size our PFO again under intracardiac echo, and this is my device closing up the hole. Once I'm happy that the PFO is completely closed off, I can release the device, and once the device is released fully, we can do another bubble study to make sure that there's no bubbles going across from the right to the left. This is how the device looks when it's deployed but still on the catheter, and once we deploy it fully, this is how it looks by fluoroscopy sitting across that PFO. Now, sometimes shunting can occur as these devices can shift because the heart is still beating. This is a device that was placed in someone with a different indication than a stroke, something called platysma orthodeoxia syndrome, in which they have their PFO causing deoxygenation because the PFO gets stretched every time they stand up and their oxygen levels drop. And I was able to close this PFO, but approximately 9 months later, it shifted into the tunnel. So we were able to go back in, place a second device using a sandwich technique. As you can see, the second device is going here to sandwich the first device and to be able to close that hole completely. And here you can see your first PFO occluder device, and then the second one in a sandwich technique, totally closing off the hole and restoring this patient's normal oxygen levels. So, what are some of the key takeaways here? Stroke is a debilitating event brought about through several different mechanisms. Controllable risk factor modification is important and can be mediated through lifestyle changes in approximately 80% of the cases, and interventional therapies for stroke reduction are effective and safe. Thank you so much. I'm happy to take questions.
Thank you so much, Dr. Shenoda, for that very informative and interesting presentation. Now we're going to move on to the question and answer session. We have quite a few questions, so we'll do our best to go through as many as possible. So if you haven't submitted your questions, please type them in the Q&A box at the bottom of your screen, and I will read them to Dr. Shenoda. Our first question is, to what degree are chronic migraines predictive of stroke?
That is a fantastic question. And although I didn't cover it in my talk, it is something that's true and dear to my heart because I did a lot of research at UCLA on chronic migraines. I was involved with Dr. Tobis, who was one of the principal investigators looking at migraine reduction with PFO closure. And there's been several clinical trials. The mechanisms behind PFO-related strokes are similar, we think, mechanisms that contribute to migraines. We think there is some debris or chemicals that bypass the lungs, go across the PFO, and lead to migraines in the brain vasculature. What those chemicals are, there's a lot of different hypotheses out there. But what we do know is that in patients that we close PFOs and they happen to have migraines, most of those patients have not complete relief of their migraines, but have a significant reduction in their migraine days when we close their PFOs. And that's how we started getting on this. Well, I wonder if we can close PFOs in migraineurs and be able to reduce or eliminate migraines. Most of the clinical trials showed that patients with migraines with aura did benefit from PFO closure. However, patients without migraines, without auras with their migraines, were equivocal. That's why the FDA never approved PFO closure for migraines. Now, in terms of whether or not a history of migraines can lead or predict strokes, that's another area of active research that we don't know if it can, because a lot of patients that come in with strokes, I'd say about half of them have migraines and the other half don't. So I don't know that that's a strong indicative feature of PFO related strokes.
Okay, great. Thank you for answering that. Besides cost, what should be considered when deciding between Eliquis and warfarin?
I think the patient's risk of bleeding should be strongly considered. I know cost is a big issue, and cardiologists tend to really want to push the direct oral anticoagulants over warfarin. And the reason for that is, as I showed from my previous slide, the decreased risk of bleeding into the brain and bleeding into other organs. So I think that's the major driving force behind the cardiology community in general wanting to push these medications over warfarin. In addition, we feel like compliance is a lot easier with these medications because you're not taking different doses on different days, and you're not having to go in and check your blood periodically to make sure that your blood is within that narrow therapeutic window. So I think ease of use and reduced risk of bleeding are the two major factors that physicians and clinicians will take into consideration when prescribing a medication like Eliquis over warfarin. Now, this is just for atrial fibrillation. It's not indicated for patients that have mechanical heart valves. That's a totally different situation. Patients with bioprosthetic or tissue valves, it's totally okay to use Eliquis, but patients who have a mechanical heart valve cannot use Eliquis and have to be on warfarin.
Okay, great explanation. Thank you. You may have covered this in the presentation, but does a high calcium score indicate a higher risk of stroke?
So high calcium score have been shown to have higher risk of cardiovascular outcomes, and in particular, usually heart attacks. Now, a high calcium score can also be associated with a higher risk of stroke, but it's indirect. And I'll explain why. A high coronary artery calcium score shows calcium buildup in the coronary arteries. Well, as we know, deposition of plaques, which become calcified in the coronary arteries, are usually not restricted to just that one vascular bed. Usually we see plaques building up in arteries in the neck as well as and in the aorta. So even though a coronary artery calcium score just really looks at the calcium buildup in the coronary arteries, if you have calcium there, the presumption is that you're going to have calcium in all your vascular beds, and that can lead to an increased risk of stroke.
Gotcha. Thank you. If a heart valve repair resolves AFib, but a left atrial appendage closure procedure fails, and the person doesn't qualify for a Watchman device, is medication the only option to manage stroke risk?
Sorry, repeat the question one more time.
Okay, so if a heart valve repair resolves a person's AFib, but a left atrial appendage closure procedure has failed, and the person doesn't qualify for a Watchman device, is medication the only option to manage stroke risk?
Medication, yes. Remember the surgical option. Surgeons can go in there now with what's called a minimally invasive surgical option, or a mini thoracotomy, where they create a small incision across the lateral side of the lung, and they're able to go in and place either a clip or a suture across that left atrial appendage. It's obviously more invasive than a Watchman device or an amulet device, but it is a second option to lifelong oral anticoagulation therapy.
Okay, thank you. That was a mouthful, but thank you. So what is the impact of high lipoprotein A combined with high cholesterol on stroke risk?
So similarly, elevated lipoprotein A and high cholesterol leads to plaque buildup in arteries. And when that plaque builds up in arteries, that plaque can get disrupted, especially if it's the arteries in the neck or in the aortic arch, and that can lead to strokes as well. So when we talked about modifiable risk factors for stroke, high cholesterol, that includes an elevated LP little a.
Okay, perfect. Thank you. And this question, you touched on this already, but our guests would like to know if you could remind us of the specific criteria or points that determine eligibility for a Watchman procedure.
Yes, so it's a CHADS 2 VAS risk score of 3 and above, and a HAS blood score of 2 and above. And this is commercially available, approved by the FDA. There are clinical trials ongoing in which we're evaluating patients with a lower risk score than that, but it's in the setting of a clinical trial in which patients are randomized to a Watchman device versus continued oral anticoagulation therapy. But outside the clinical trial setting, the FDA approval is for a CHADS VASC of 3 and a HAS blood of 2.
Okay, perfect. What other conditions can cause heart conditions can cause occasional fast and irregular heartbeats?
There's a lot of different arrhythmias that can cause an occasional fast and irregular heartbeat. The most common one is a supraventricular tachycardia. And there's several, that's a grab back term for multiple different tachycardic episodes which arise from the top chamber of the heart. Those tend to be a little more organized. Atrial flutter, which is kind of the cousin of atrial fibrillation as well. And we kind of group atrial fib and atrial flutter together, which is mostly a reentrant circuit on the right side of the heart, whereas AFib is mostly on the left, but can occur on the right as well. But supraventricular tachycardias is another large grab bag term for different types of arrhythmias that are more organized.
Okay, perfect. Thank you. So if age is your only risk factor, is it possible to prevent AFib and therefore stroke?
That is a great question. It's really difficult to prevent atrial fibrillation as you get older, because as you get older, what happens is the heart starts to stiffen, right? As with anything in life, things get worn out. Just think about the parts on your car. The more you drive your car, the more miles you put on your car, the more the parts start to wear out. Well, the heart, after beating so many times, it starts to stiffen up. And patients, as they get older, they tend to develop something called diastolic heart failure. And that's when the heart squeezes normally, but it's having a difficult time relaxing normally because the heart's gotten stiffer with age. That leads to increased pressures in the left atrium. That causes the left atrium to dilate. And as the left atrium dilates, your risk of AFib increases. And so there's not much you can do about that because that's part of the normal aging process, the diastolic dysfunction that leads to the enlarging left atrium that can lead to atrial fibrillation. So that's something that's just a natural part of aging. With that said, not everybody gets AFib in their 80s and 90s. And we don't quite understand why some people are more prone to developing AFib than not. So 80 to 90% of the risk factors are controllable, but 10 to 20 are not.
Perfect. Thank
Age
you.
is one of those uncontrollable ones.
Gotcha. Thank you. Well, we're actually over our time, a few minutes. So I'm going to pose one last question before we close.
Sure.
Does the Watchman procedure affect atrial fibrillation?
Yes. So the Watchman procedure can affect atrial fibrillation in the sense that when you have a device healing in the top chamber of the heart, inflammation can ensue and it can actually kickstart atrial fibrillation as it's healing. So in those patients that tend to have symptoms from their atrial fibrillation, we warn them that your atrial fibrillation may get a little worse when we initially implant the device as it's healing, but over time, as the device heals and the inflammation goes away, the atrial fibrillation tends to settle down.
Perfect. Thank you so much, Dr. Shenoda. This has been super helpful. So for everyone who participated, thank you for all of your questions and for joining us this evening. Dr. Shenoda's office is located inside Santa Barbara Cottage Hospital in the new Structural Heart Clinic, on the fourth floor of the Pueblo Pavilion. Immediately following this presentation, you'll receive a link to request more information or have a member of Dr. Shenoda's team reach out to you and make an appointment. We will also email a recording of this presentation next week. If you have further questions or would like more information, you can always call 805-324-9012 or visit cottagehealth.org/heart. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. Thank you again for joining, and have a happy and healthy rest of your evening.